You're listening to Rise Above, a Rogers behavioral health podcast, where we sit down with Rogers experts who are changing the way the world views mental health and addiction. Today, we are talking with psychiatrist Peter DeVries and clinical psychologist Nicole Stettler about avoidant restrictive food intake disorder, or ARFID. So while people can be more familiar with eating disorders like anorexia nervosa or bulimia nervosa, they might not have heard about avoidant restrictive food intake disorder. Can we start off by defining what it is?
So ARFID, which is a lot easier to say, so I think we can move forward with that, is defined as an eating disorder where someone isn't eating enough in terms of either volume or variety or both of food to meet their nutritional needs, and it has to impact them in certain ways. So impacting their physical health by either impacting their weight, causing a significant weight loss or failure to achieve expected weight gain, or causing nutritional deficiencies, or causing them to end up to be dependent on supplements, or cause some sort of really big interference in their daily life and functioning. So not being able to do things that they want or need to do in life because of their eating preferences.
So then that leads me to my next question. How is ARFID different from picky eating?
Yeah, I think when I think of ARFID, it really is, as Dr. Stettler kind of mentioned, like impacting us quite a bit socially, where we're not necessarily able to do kind of the things we typically enjoy throughout a day, or where the level of restriction of food variety or volume is leading to really significant medical or physical impacts. So that can be really significant weight loss. It can be vitamin deficiencies or electrolyte abnormalities. And to the point where they kind of probably do need treatment for it. Another thing is looking at, picky eating is relatively normal, I think, in little kiddos, kind of throughout their younger years. But typically that kind of can improve over time. And it's not necessarily as much like fear and high levels of anxiety. And in ARFID, it really is just like a lot of fear, a lot of anxiety, or just no interest at all in food variety.
Mm-hmm. So I noticed you mentioned, kids, and completely understand that. It's just, this is brand new. I've never seen this food before, but is this something that happens in childhood, or could ARFID happen at other ages?
Yeah, it can absolutely happen at any age. So I think that there are different, like some people, you do see more of a long-standing course of ARFID. So these might be people who kind of went through that picky eating phase as a child, and then it just kind of persisted throughout their life into their adult years. We can also see onset like just later in life. So that probably would most likely happen after some sort of event. So it could be after, a choking or a vomiting episode, or it could be after like medical treatment, for example. Sometimes someone experiences medical treatment for an unrelated condition, and that might really impact their appetite, and then that kind of sort of spiraling and turning into something else, and kind of keeps them stuck in these eating patterns that have developed later in life. So really could be either. Absolutely.
Can ARFID also lead to health issues like anorexia nervosa or bulimia nervosa?
Yeah, that's a great question. So ARFID definitely can have the same kind of medical consequences that someone with anorexia nervosa or bulimia nervosa could have. So, very oftentimes when our patients come in, they have electrolyte abnormalities just because of how, severe their restrictive intake has been. They can have that weight loss. They can have difficulty with like thinking clearly. Their heart rate can slow down. Their blood pressure can be lower. Really restrictive intake is restrictive intake, so it can affect kind of any organ system in our body. And for some, if they kind of come into treatment later or are really, really struggling, it can be there can be really pretty severe medical consequences.
What other mental health concerns may also show up when someone has ARFID?
Yeah, it it can often go along with, I mean, really a lot of different presentations, a lot of different other mental health concerns can go along with it. But I think some of the most common probably tend to be anxiety disorders, OCD, depression. Sometimes that can be separate from the ARFID. Sometimes it can be as a result of kind of being undernourished, and kind of our bodies just kind of, and brains tend to get more depressed when we're not eating enough. Sometimes it could also be that depression leads to low appetite and lack of interest in eating. So they can kind of be related in different ways. We do also see that ARFID seems to be a little bit more prevalent among certain neurodevelopmental populations. So kind of high degree of co-occurring with autism spectrum disorder, also with ADHD, and then with some of the medical concerns that we kind of touched on earlier. So, gastrointestinal problems, but also like other medical conditions that might predispose someone to have to change their diet, or to just kind of feeling unpleasant sensations in their body that impact their eating habits.
Sure. So what does treatment for ARFID look like?
There's various levels of care. So at Rogers, we have inpatient, we have residential, we have partial hospitalization. So it can be anywhere from like 24/7 nursing monitoring, meeting with a provider every day, to kind of Monday through Friday, 8 to 3. And then there's individuals, obviously, who are just working on things as an outpatient as well. So wide variety of levels of care. In my mind, ARFID should really be a collaborative approach. I think there's a role for medications, and so having a psychiatrist on board can be helpful. Obviously, having a therapist working through potentially some exposure-based things, or a wide variety of kind of CBT-based models can be helpful. A dietitian is extremely helpful, looking at food variety, weight status, things like that. And then, again, because of the medical consequences, it's so important to have a primary care physician or a medical provider on board who's just making sure we're not kind of decompensating medically. And I think that combination of, CBT or exposure or family-based therapy, medications, nutritional support, it really all is needed to kind of have the best outcomes and best results for treatment of ARFID.
So Dr. Stettler, regarding that this is an emerging area of research, are we starting to settle on what one would consider would be the best evidence-based approaches for treating ARFID, and what would that be?
Yeah, I think the literature is definitely converging around sort of cognitive behavioral approaches with a strong element of exposure, and often combining family approaches or involving family as well, especially when treating children and adolescents. So far, the converging literature is all based off of kind of not the kind of gold standard research that we look for. So there's no randomized controlled trials yet, but we do have now a number of pilot studies. And I think just the accumulation of evidence is part of what helps guide my thinking of, we've got multiple kinds of research studies, and they all seem to be kind of pointing in the same direction. So I think we're getting closer in being able to help guide what our best practices would be, at least when it comes to the therapy approach. As we saw earlier, medication's a little less so at this point.
So what's one piece of advice that you would give parents whose child may be struggling with picky eating, and then they're starting to suspect that it might be something more than that?
From my perspective, depending on the age of the child, maybe having a conversation with them about what they're really struggling with, what kind of concerns they might have. Individuals with picky eating can definitely develop ARFID and kind of more feared food types and food variety and different sensations. Individuals with picky eating can also develop other eating disorders, such as like anorexia nervosa, where maybe the concern is more body image or weight gain fear. And so just having that conversation with your kiddo can be pretty important. I think in my mind, if there is like a lot of preoccupation of food, if they notice like weight is trending, if they're just acting a little bit differently, maybe more anxious or mood changes or anything like that, so important to reach out to your primary care physician, or if they are already involved in mental health care, kind of bringing it up to their therapist, because what studies show with eating disorders is getting treatment earlier typically has the best outcome. So not wanting to necessarily wait on anything to the point where now we're very medically compromised and it's tougher, just a tougher treatment at that point. So just if you're concerned, reach out and try to get some help from someone else.
I think what I would say too is just validating, like, it's such a tough position for a parent to be in. Like, you know, your number one job is to keep your child alive, and feeding is a big part of that. And so there's so much pressure that I think parents can feel. And then that can often be really hard for them to manage. And that can turn into, again, sort of unhelpful patterns of either maybe overly accommodating and kind of giving in ways that ultimately aren't going to be very helpful, potentially in the long run, or becoming having a lot of pressure that they're then putting on the child and making these really negative dinner time or meal time interactions between parent and child. So I think anything that they can do to kind of manage their own stress, if they're co-parenting with someone, getting some support from that other person so that you can kind of tag team when you notice that you're feeling a little bit frustrated. And I think also reaching out for support. There are a lot more resources now, certainly than there were even 5 years ago for ARFID. There are parent groups and support groups. There are websites. There are some books now that are available out there for parents and caregivers more specifically, or for patients. So I think there is more information, just so that people can also feel like they're not alone. They're not crazy. There is something that's going on. And to I think trust their instincts too, of like Dr. DeVries was saying, if it's seeming like it's not just meeting, you know, when you're talking to other parents and they're saying like, oh yeah, my kid's a picky eater too, and you're like, no, if there's something different here, trusting that instinct and reaching out for some support and help to catch it early and to be able to try to intervene and get some supports going as quickly as possible.
So I think that's really, really solid advice. What would be one key takeaway message you would like people to know about ARFID?
I think from my perspective, in terms of awareness, I think it's important to recognize that like not all eating disorders necessarily have that concern over body image or that fear of weight gain. I think oftentimes, like when we discuss eating disorders, even during, you know, as medical providers, like we just think of more stereotypical cases of kind of individuals who struggle with that. But ARFID is, you know, has the same medical consequences, but that body image fear isn't there, and that, you know, still can just be as serious, and they need the treatment. And again, getting treatment earlier the better. So I think that would be my main takeaway for individuals out there.
Yeah, I think similarly. I think what I hope people I just hope there's more awareness that ARFID exists and what it is. And I think that I do think there's something important to know about the fact that just being patient a little bit with the field, because it is such a there's so many different people within that umbrella term of ARFID that can look quite different. And so even some of the things that we might talk about as recommendations for someone with ARFID may not apply to all people with ARFID. And I think that some of this is just us catching up with, you know, what are those different presentations? What are the best kind of techniques and supports? And so I think just being patient as we continue and recognizing that if advice changes in a year or 2 years or 3 years, it's not because, you know, we didn't know what we were talking about back then, but it's just because there's new things that are emerging every day, and we're all kind of trying to come up with the best ways to talk about and to understand what's going on and to be able to help people. And I think that is always a good takeaway message too, that help is recovery is possible, treatment can be effective, and reaching out for help is super important, even if you don't feel like you and I think going back to Dr. DeVries' point, even if you don't meet some of the classic eating disorder symptoms, I think that often turns people off from like, I don't even know where I'd get help or how I'd get help, or if this is something that I should get help for. So I hope that awareness for everybody starts to make it feel like people have a place to go to reach out for that support and get help.
Well, thank you both for taking the time to talk with me.
Thanks for listening to Rise Above, a podcast from Rogers Behavioral Health. Be sure to like and subscribe to be notified of new episodes. As always, if you or someone you care about is struggling with a mental health or substance use disorder, visit rogersbh.org for a free mental health screening.